It's great to have you here, Paolo.
Great to see you, John.
I'd like to first start by asking you about what non-ED based sexual dysfunctions do you talk to your patients about prior to prostatectomy?
Yeah, so normally there are several so-called neglected side effects that patients should be aware of, and especially concerning orgasmic impairment, which means painful orgasm or impaired orgasm at all, and sexual incontinence, which means arousal incontinence or intercourse incontinence, orgasmic incontinence. And then it is important that they should be also counseled about possible penile morphometric alterations, volume loss or penile length, reduce of penile length, and then also issues related with sexual desire.
So perhaps we can start talking about the concept of sexual incontinence. There are two types of sexual incontinence. Can you kind of describe what they are for us?
Yeah, arousal incontinence basically is something that it is very difficult for patients to control because it happens during the sexual intercourse overall. I mean, it can happen before penetration or during penetration. It is completely unpredictable. While orgasmic incontinence, which is called also climacturia, normally happens at the moment of the orgasm, where patients normally lose a few drops of urine.
And what's your general approach to management of both of these problems?
So to manage arousal incontinence it's quite difficult, especially because it is unpredictable in timing, as we said. But in general, for both, you can have some conservative suggestions that you can give to the patient, such as voiding before sexual intercourse, for example. Then the patients can use a penile tension loop. Of course, they have to fully recover their urinary continence, and pelvic floor rehabilitation is very helpful in that. Otherwise, for severe cases, we have surgery.
And you mentioned already the concept of penile volume loss. Can you explain to us how that occurs?
Yeah, penile volume loss is related to penile fibrosis, basically. All patients, even if they do a very fine nerve-sparing surgery, they will end up with a short period of temporary impairment of the vascularization of the penis due to a damage to the nerves, a temporary damage to the nerves. And so this will result probably in penile fibrosis, which will result in volume loss and shortening of the penis.
Is there any strategy that you use to try and minimize penile volume loss in these patients?
So to minimize penile volume loss, you should, first of all, of course, perform a nice surgery. And then you should ask the patient to try to have sexual intercourse after surgery, after a reasonable period from surgery, using erectile dysfunction medications. And this will probably help in keeping the tissue alive, I would say, well oxygenated, and this probably can help in reducing the risk of volume loss. Then there are other devices, such as vacuum erection devices, that can be used also to reduce this risk of volume loss.
And let's finish up with the concept of sexual desire changes after prostate cancer treatment in general. How would you approach that?
So sexual desire changes most of the time is related specifically with the idea of having cancer for the patient. So it is something that should deal also, we should involve also psychosexual counseling for this patient. But we have also to check, for example, testosterone in these patients because they may have hypogonadism. And in this case, if they have been treated with a radical treatment for their prostate cancer, and they do not have an high-risk cancer and they are free from disease for 1 year at least, so then we can consider also offering testosterone replacement therapy.